So yes, I am a clinician. I am an ENT clinician. I work a lot with patients with vertigo, dizziness, and tinnitus, and problems in hearing problems from the clinical point of view. So vertigo, to remind you all, is a spinning sensation. It's a sensation of turning. You can turn this way, you can turn vertical way, you can turn this way. Usually it comes from different reasons, but mainly from inner ear dysfunctions, as a difference between one ear and the other, especially in the function of the semicircular channels, comes faster, and it's a bigger difference between one and the other ear. The vertigo is going to be more terrible. And so people feel that they are moving or the surrounding is moving, mostly turning. And to feel dizzy is something different. It's something like flotating, or that your head is too big, or that your head is too heavy, or is too light, or like a rocket sensation that you go there in the air. And you can have many different etiologies of this sensation, including inner ear dysfunctions, which I think it's very, very important. It makes most of my consultations these days, people that are dizzy, and they can have some structural lesions that came first with vertigo, and after that they are feeling dizzy, or they begin directly feeling dizzy, like when they have a problem, for example, in the utricle or the saccule, and they don't feel okay, the gravitational sensation. So which vestibular pathologies can have associated tinnitus? And there are many, many pathologies that can have associated tinnitus and vestibular symptoms. But as the most uh, as the most known one, or the model one, we can have the Meniere's disease. It can be the definite or the probable. I'm not going to talk about all the characteristics of the disease, because you can read them, or might be you also know them. And this is like the traditional model. But also I have many patients that come to my consultation and they have vestibular migraine, and they can because of suffering tinnitus. It can also be definite or probable vestibular migraine. And people come to my consultation might be because they feel dizzy, or they feel vertigo, or might be because they feel tinnitus. So what do these diseases have in common? First of all, they are chronic and they are fluctuating diseases. And for me, here is a very important point, because when a patient comes, I can say, well, yes, he's got or she's got a vestibular migraine or a Meniere's disease, but what I need to know is which is the functional situation this moment, which is the situation of the inner ear, or might be of the auditory or vestibular way, to know or to decide which is going to be my first treatment, or how I'm going to help this person. I'm all day hearing people, and I got to give an answer. And it's not that, well, okay, you have tinnitus, and then I don't know where I'm going to. So I've got to like follow a model of working on these people. So why do they have tinnitus? Might be because their neurons in inner ear or in pathways have suffered in some time, or are suffering now, endolymphatic hydrops, or might be because other situation is happening now. But what they have in common, most usually, what I see is that when they come because of the tinnitus, is because something with the hydrops is going on. Something is changing. They're having a situation where hydrops is high, or something like that in that moment, especially patients with vestibular migraine. So, what is endolymphatic hydrops? It's an excess of endolymph, and we can measure it in different ways. We can make functional studies, which are very, very good here in Argentina because audiologists here are not like like what I've seen in some other countries that are nurses that do the audiological tests. They are audiologists. They are very, very good working. So we can do electrocochleographies to search for endocochlear hydrops or CBEMs or ORBEMs, which are vestibular evoked myogenic potentials that study the function of saccule and utricule, which are the receptors of the gravity sensation, the otolith receptors. There we can use comparison between 1000 and 500 hertz and responses. And when you do it in young people or middle age people, you can have an idea or you can have a measurement if they have hydrops in one of these receptors. Also, you can know functionally when you do a caloric test and you have no answer, and you do a video head impulse test and you have an answer in the same channel, that you have to suspect that in that channel you have hydrops. And for me, this is very important because we can study all parts of each ear when people hear, and I can know which is the situation right now and what am I going to do with this situation. If patient is deaf, in my case, I know in other countries, people use MRI with hydrops protocol in all patients, but in my case, in patients who are deaf or near deaf, we use this other technique, which is a definite way of showing the presence of hydrops. But for me, it gives me poor control of progression or regression of hydrops. How can hydrops change? I cannot do an MRI with this quantity of gadolinium to a patient and repeat it 2 months after. It's going to be too hard for these patients, and also it's going to be too expensive. So usually we work with functional studies and we ask for MRI with hydrops protocol when we cannot do the other studies, especially electrocochleography, because, for example, patient is there. So this is how I think it when I have the patient in front of me. I know that there are patients who have Meniere's disease, and in some time they are going to have hydrops, and might be it's going to be important, this situation. And also, I'm going to find some patients that are going to have what used to be in 1971 the partial Meniere's disease. That is, they are going to fluctuate in the inner cochlea, or only in the vestibular part of the inner ear. And this I call Menieriform type. So also it behaves in the same way with changes that I can measure in the audiometry. But also I have many patients that have fullness, tinnitus, dizziness. It is not Meniere, it is not vestibular migraine. So I call them inner ear hydropic disease. This has been a name that Professor Perez Fernandez proposed for all these situations. But for me, I just adjust it to this clinical situation. And also, there are people who have inner ear hydrops without symptoms. This has been found and well documented in MRI that use this hydrops protocol that gives them gadolinium and makes the MRI 4 hours later. So this is what I call hydrops not Meniere. And also, I always pay attention to see if they are migraineurs or they have characteristics of migraineurs. Because in any of all of these situations, people can also have migraine symptoms, and these can make differences in the evolution or in the situation of the patient, and of course in the treatments I will give them. So these are the different tinnitus groups that I see associated with hydrops in my consultation. And now we are working only with a group of in this presentation with a group of patients from the British hospital. So this is the number more or less 305 with Meniere's disease. So we are going to analyze 177. This is the number of vestibular migraine, and this huge number of patients. These patients don't have Meniere's disease, they don't have vestibular migraine, and they have tinnitus and hydrops. So this is the whole number of the group, and I took something like samples of 250 from vestibular migraine and inner ear hydropic disease to analyze now. We are analyzing just some data that are very important for me to decide what I propose to my patients. So the composition of the groups by sex, in Meniere's disease, most men. I always see almost more men than women with Meniere's disease here in Argentina. And in vestibular migraine, migraine is always 5-1 in women comparison to men. So yes, of course, they are almost women. And in inner ear hydropic disease, it it behaves more or less like Meniere's, This doesn't mean that these patients are going to be or are going to have Meniere after. No, these patients have this inner ear hydropic disease and stay like this all the time I follow them. And, I've been an ENT for 27 years, so I have followed long time patients. And only one patient came from this group and went to have a Meniere's disease 5 years after. So this stay in this fluctuation of the hydropic situation of the inner ear, and I don't find any special. I cannot put them in any special diagnosis. So here we have the mean age. The mean age is more or less around the middle time of the life for everyone. And now we're going to see how many of these patients came to me because of the tinnitus. How many came to the consultation because of tinnitus. And here you see that most of them are here in the group of inner ear hydropic disease. So when we check the electrocochleography, at the first time, the electrocochleography has this relationship normal up to 35%. We see that the highest values are here in women with Meniere's disease and in men with inner ear hydropic disease. And this is the treatment I give them when I found they have hydropic disease. So they have vestibular migraine or Meniere's disease, but they have these hydrops in the inner ear in that moment. I begin with beta-histidine, orally 2 months. I give different dosage, depends on how is the level of the hydropic situation. And I add diuretics only for 2 months. Always Professor Stroop says that it didn't show up that the diuretics are going to be useful, but I found it useful in my patients. I ask them not to eat an excess of salt, and if they are bilateral, we add anti-inflammatory diet, gluten-free and with no sugar. And also, if they have what is called chronic daily headache, which is more than 15 days of headache in the month, or if they have vestibular migraine, we add vestibular migraine prevention therapy. My objective is that the patient must have no hydrops, or hydrops must come down so that they have less risk of having vertigo, feeling dizzy, having fullness, or sometimes hyperacusis. And that after this, might be they will have better response and tolerance to sound therapies. So here we see the THI before and post treatment. Here the worst THI at the beginning of treatment has been in males with inner ear hydropic diseases, not with Meniere's, not with vestibular migraine. These are always the patients who came to me just because of tinnitus. And I always ask for this residual inhibition treatment because many of the patients I'm going to offer some kind of sound therapy. So I want to know if they are in condition of receiving sound therapy. So many of them cannot receive the therapy because they have this rebound effect with sound. And if I give them sound, they are going to feel worse. And they are not going to like this. And also, I'm not offering them any hearing aids in this moment. And if it's negative, and also they have in the same moment hydrops, I don't offer them this treatment until I correct the hydrops if possible. So we do the measurements after treatment. This is after 2 months of the combination, and here you see the differences. So much more patients to have a positive response to sound, much less patients have rebound effect to sound. So for me, this is what I do in these tinnitus which are not pulsatile. I do well with a normal physical exam and a basic MRI normal. And I do all the audiologist tests, but I always include electrocardiography. If they are deaf or near deaf, I ask for the MRI with the hydrops protocol. And if they feel dizzy like being on a boat or like floating or things like that. Uh, don't matter if it is fluctuating dizziness. I always ask also for the C and O BEMS in 1000 hertz frequency. So for me, hydrops should be ruled out in all patients, especially if sound therapies are used for treatment when they feel dizzy or when they feel vertigo. And I might say, I don't know if they don't feel dizzy or vertigo, if I should do it to everyone also. Because in the first moment, we did these studies only to people who had a hypoacusis or tinnitus under frequency 2000 hertz, like when Meniere is beginning. But then we decided to do it in all frequencies. And sometimes you find a patient who has an acoustic trauma with 4000 hertz tinnitus pure tone, and then you do this and they have hydrops. And you want to give them a sound therapy and it doesn't work or they don't tolerate it. So as final concept for me, endolymphatic hydrops can be present in other pathologies affecting the inner ear but Meniere's disease. The presence of endolymphatic hydrops in these patients provokes negative or rebound effects in residual inhibition tests, and the evaluation of hydrops presence in tinnitus for me again, patients before beginning sound therapies might be helpful. So when I sometimes read or hear conferences when people are saying this treatment or the other for tinnitus and no, they don't check the presence of hydrops, then I said, in which situation are we talking about these patients? Because you can have patients with Meniere's in the last situation of the Meniere when they don't have any more vertigo and might be they don't have any hydrops. But you can have it when you have a patient that comes in the after the third vertigo crisis. And that's very different functional situation. And for me, that defines what am I going to do to help all these people if I can do that. Thank you very much.